There is a school that people can, it's kind of like a magnet school, but it's in Rhode Island, and it's called the Compass School. And it's right next to URI. And they have a working farm. And they go up, and just started, they go up to 8th grade, but it's a much more open kind of a situation for many kids where I have 2 patients, one who's in the 8th grade and one who's in, I think, the 4th grade. And they are thriving in it because it's more hands-on,
Yes.
much more hands-on. And so more experiential, a little more breaks are brought in because they have to work on the farm, is allowing for many kids, especially those with ADHD, to flourish. The other thing is, think about what's going on with the pandemic. It is so difficult for kids to virtually learn and be home and not be distracted and have to watch a screen. Now, they love the screen, but only if it's video games. And so, but it's very, 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 very tough. And now, fortunately, many schools are allowing some of these kids to come back 4 days a week, where they can be more, they can advance better, because we're going to have a lot of kids way behind when we return full time to the schools, hopefully the next fall, because of it.
Yeah, when you say way behind, I'm seeing too that some kids, because a lot of it has to be self-initiated, and they're just looking into a screen and having to submit 20 plus assignments in a week for some.
Yes.
It's like, you talked about that motivation, motivation, and they get overwhelmed. When I see.
Totally. Yeah, it's very, very, very trying. And the onus is on the parent, unfortunately, to keep them on track. And but don't forget that many families, the parent has ADD too. So
yes.
So organization. I think the invention of the whiteboard is the greatest thing going. So, and I tell all families, get a whiteboard. If put it out there and start setting do it day by day, what the goals are, what you want to be done that day, and build in, after each one of those, build in a reward system. So,
can I ask you about that?
Yeah, I'm stammering here because I used to say, this is funny. I used to say, these are the Donald Trumps in the world. But now, I don't want to be political at all. But the art of the deal, when he wrote that book, I say, these are individuals with ADD. They'll do anything for money. And I used to say, don't bristle, because you can buy them off. And so reward systems are excellent. And that's one of the things Russell Barkley has really encouraged, is to set up reward systems, but things that can be done easily. It doesn't have to be, so people would say, if he gets all A's, we're going to go to Disney. No. Let's take what we're going to accomplish today only. And so the reward systems have to constantly be changing, because they like new things. It has to be changed at least weekly. You got to change it. For if you make your bed, you get up, you brush your teeth. Well, then you're gonna. Believe me, that's a huge accomplishment in many families, so that the morning routine comes off okay, because individuals with ADD can set the pace for the whole family and bring the whole family down very easily. And they do know how to get right to you. They go right to the core. They don't play around. They go right to it and can make your life miserable at times. So very, very trying parenting at times with kids with ADD.
So if we could talk more about those strategies. So I love what you're saying about the instant feedback of the reward. So oftentimes parents have these expectations, but they in their own mind, set the standard, but it may not. So they kind of have to negotiate that with their child if they really.
Absolutely. So rather, discipline is very variable, and it's very challenging in families where there are more than one child, because individuals with ADHD don't really waver or change due to the usual forms of discipline. So I recommend the book, The Explosive Child, and it really is about what is called collaborative problem solving. And that is where you really work to negotiate. You work to negotiate what is going on. Okay, so we'll back up the bus. There's a conflict going on at home. The parent usually wants to play the disciplinarian role to the child, and they lock in and engage. And fathers and sons in particular have the worst time, where they really are power play. Okay. No one's going to win. The doctor who wrote the book, Ross, forget his first name, but he wrote the book, The Explosive Child. And he actually hated the title of it, but he took all the money and put it into a website called www.livesinthebalance.org. And it's a terrific site where he has videos about how to do this collaborative problem solving. So instead of locking heads, this is when you use timeout. That's to be a benefit, and say, okay, let's take a break. You go to your room, I'm going to go to my room. Let's both settle down, and we'll reconvene. How about tonight before you go to bed, we'll talk about it. And at that time,
timeout is another word for space, right? Let's take space.
Exactly. Take some space, and saying that we're just in a position where we're just really struggling here. And so what you do then is then at night, then go in and say, okay, what was that all about? And one person starts, you ask the child that, then he says, well, you wouldn't let me play PlayStation, and I didn't get my 10 minutes. And then you say, well, you didn't finish your math homework. And then you go back, and so you're going back and forth and going back and forth. And what you're actually doing is trying to have the child figure it out himself. A better way to have done this, wouldn't it have been better to finish the homework rather than try to sneak in PlayStation, that kind of a thing. So it's a, I keep saying, I told you, I forgot his name, is Ross Green. And he's at Boston Children's. And I actually went and did a conference one and did an afternoon with him in one of these settings where we all had to play kids and parents, and it was really hilarious. But you can see it's a different way of approaching approaching discipline and getting work completed without locking in and engaging in just a screaming match, which often occurs because the emotions keep rising and rising. So
yeah, and you're really speaking to, for me, I see a lot of the authoritarian style as opposed to the authoritative style, which is definitely the more negotiating style and the more assertive. The authoritarian is more of, I am the father, you do as I say, and
that's right.
I'm not going to tell you why.
This is not a democracy; it's a dictatorship here. Exactly. Yeah.
Any other strategies that you could pass on to parents, and even in the when you consult with the family, because I know it's about an hour consultation.
Yeah.
When they ask you, Dr. Blefeld, I'm so frustrated. I don't know what to do anymore. I don't know.
Well, this is it. And everyone, they usually I would say 100% of families that come into the office and we sit down and have this conversation, they all have reached that point of frustration, and they're pretty miserable, and everyone is in a demoralized kind of a state because school isn't going well, home life is really being impacted, and so medication is not just the only thing. That's where I say, call Jason. And I say, this family needs really more. They need assistance and support. And so that's where, and unfortunately, we used to have a CHAD division that a woman in Waterford was running it, and we used to have regular meetings, and it was wonderful. She moved out of the area, and unfortunately, but we had great speakers that would come in, and pretty well-renowned people. And Ned Hallowell was one of the people, and he's written that book, Driven to Distraction, for adults. And he's a terrific, and now runs an ADHD attention center. Families need support, and it's very rough when they don't have it, and the kids feel isolated, and that they're the problem child. And so counseling is really very, very important for many families. And as I said, one of the things that I end up doing is really talking about treatment modalities, and that's really where most families or most parents I can carry to this point. And then once I say the word medication, whoosh,
really,
they're like, whoa, I didn't want to go this route, that kind of a thing. So we have to then really discuss what does medication do and what are the different modalities. So so there used to be a whole bunch of people who would get talking about diet and food additives, and everybody knows the day after Halloween what their kids are like after they've eaten a whole bag of candy. Sure. And so we've all suffered through those days too. But in reality, there's a husband and wife team, Bennett and Sally Shaywitz, and they are recent pediatric neurologists down at Yale, and they did the studies on food additives and sugar. Does sugar cause ADD and the behavior? And they proved that it didn't. Yet we all know, anyone with a child knows what sugar can do to some kids. But when put to the test, they showed that it didn't work.
It does not. Yeah. And are there any other, because you're talking about misconceptions too, or just a lack of proper information, any other misconceptions that you can speak to?
About the diagnosis?
Just about what causes ADHD, or what contributes to it, because you mentioned.
Well, so there's a lot. So we talked about the genetics, but there are people that have been. So we do know that kids who have had that are children of parents that have been abusing drugs, or that have been going through withdrawal, we know, or very premature babies that may have had some impact on their brain development. Heavy metals like lead, that's why lead is being screened routinely in pediatric offices. So there are a lot of different things that are the possibilities for ADHD, other than just the pure genetics. But far and away, genetics is really the biggest part to all this. And we take a history of the other families as well, and ask about other mental health issues, or even then we have the whole nother bag of autism as well, where developmentally people are concerned. And so we worry. And the other thing that you have to always think about is this truly ADHD, or is this a learning disability? So picture the teacher, picture the child in class who, let's say, has dyslexia, or which is a reading, a broad term for a reading disability. And I had mentioned Shaywitz, Sally Shaywitz actually wrote the book called Dyslexia. And they have done a huge amount of studies. And one of them recently was probably about 5 years ago that they presented at one of the conferences in Boston about dyslexia, and said that when reading is disproportionately hampered in comparison to their ability, their intellectual ability, then that is the definition of dyslexia. So when I'm sitting and talking with families and they say, everything else is just fine, but reading is like impossible. We can't go anywhere with reading. Then I say, okay, now picture the child in a classroom where the teacher is reading stuff to the class, to the students, and this child is not getting any of it, or cannot read, or they've written something up on the board and the child's trying to do it. And then by the time they try to read it, it's being erased and moving on to the next thing, and they're missing it. Well, when the teacher looks over at the student and sees this kid is looking around and not focused and not getting and not attentive, it looks like ADHD, but it isn't. If we can enhance the reading, or do it through the ears, have everything read, then that may ease that frustration up. So you have to look at a whole bunch of things. And when you see disproportionately one subject being impacted more than anything else, that's when I write a letter to the schools saying, this is a child that needs to be fully tested with what we call a psychoeducational assessment, and look at how they're processing information. Because kids, if they have a disability in that regard, they may be unfocused, unorganized, and have an inability to process information.
And I think you're alluding to, that's where at those points for me, I refer out to Dr. John Kimpton, the neuropsychologist.
John and I go way back, and he's terrific. Now, John though is a neuropsychologist, so he does neuropsychological evaluations, whereas the school does. So his evaluations are far more are greater in terms of testing than what the school will do. And the school has to provide this, if indicated, free of charge to the families. John's is different, and it's a lot more time intensive. And when we can't figure out from the testing done through the schools, through their basic IQ testing, the WISC, when they look at their reading, and they look at reading, and they look at math skills and writing, and they say, there's nothing there, but yet you still feel there's something more going on. That's when we refer to John Kimpton or other neuropsychologists to really do a greater battery of testing.
I know a lot. You mentioned medication earlier, and in his evaluations, he has recommendations at the end of his reports, and he talks about psychotropic medication. This is such a big topic. Can you give distinctions between the stimulants, the non-stimulants? Because I get tons of questions on what people should consider, what clients, they really don't have really good information on what the differences are and how they contribute to
Okay. So So as a matter of fact, these things are terrific because they have all the medications and they're up, but this is, I don't even know if this is fully updated, but this is all about, this is all the amphetamine based medications, and then the non-stimulants are here. We'll talk about that. And then over here is all the Ritalin based medications. So, but before we even get to that, I mean, the most important thing I tell families, because as I said, they get very concerned and worried about prescribing medication. I say, one, if I was talking about a child with diabetes, would they even question that they would have to be given injections to their child 1, 2, or maybe even 3 times in a day? They wouldn't question it at all. And I also tell them, and I try to talk to the kids very specifically as well. So I will not see a family for an evaluation unless the child's sitting right there, because it's very important to engage them in the treatment plan. And I tell them, I can get through life without my glasses. I would do a lot of squinting and holding things way out, but I can get through. They can get through their life without medication, but the quality of their life. So quality of life is, to me, the key. And it isn't just quality of life for that child, it's quality of life for the family. Because you picture a weekend with a hyperactive child and where they're yelling, Johnny, 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 Johnny. After a while, Johnny wants to change his name because he's tired of all of it. And so it does affect everybody. And one of the things that came out in this is going back 5 years, because that was the last time I was at Mass General for they have a yearly psychopharmacology conference, and it's all for ADHD, and it's 7 in the morning to 9 at night, 7 days. The most intensive conference you've ever been to.
Sounds it.
And the syllabus, when you leave, it's this thick. But when the last one that I went to, when I left there, the only thing that I came home with that was really, 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 really striking, that's my take-home message to families, is that now with PET scans, that they have functional MRI scans. So MRI scans now look at pictures very, very well of the different organs. However, functional MRI scans, which are still investigational and not fully available, look at the brain activity as a task is being done. So they show up. So as they're being scanned, they're looking at increased activity in certain brain areas, and they light up. Now, what they did, and this was a huge study that had been done in multiple centers, including they even had functional MRI studies in Hartford Hospital has one. And just on an aside, they were looking for patients with hyperactive ADHD, and I sent a couple of patients in because they were paid $600 cash.
Oh, wow.
Yeah. Oh, that's what the kid said. Oh, wow. Sign me right up. So they wanted teens, and they were thrilled to go up there just to sit there and get a functional MRI. And the tasks that they're given are mental computations. So one of the things about this particular thing showed that so they did them before treatment with stimulant medication, and then followed them out. And what was the most impressive thing was that when I first began training was that you were told every day's a test day. You don't give your medication, the next day you're right back to where you were. There's no carryover. Oh, by the way, do you know who the smartest companies in the world are? Car rental. They won't rent you a car till you're 25.
Oh, the brain development?
Brain development. Frontal lobe doesn't fully develop until age 26.
Wow, I didn't even think of that. Wow.
So they won't rent you a car until you're 25 because your decision making is your frontal lobe is age 26. Now, so they did these studies at functional MRI and showed that there was permanent and positive improvement in brain functioning on kids with stimulants who were started young.
And when you say young, is there a general age?
It's usually third, fourth grade. Usually third, fourth grade. And those people who didn't start medication until after age 26, they're on it their life. You started before 26, and now because I'm at the later part of my practice again. See, right. I'm still practicing.
Here comes that word again.
I'm still practicing.
Right.
But I'm seeing kids coming off medication. So they're coming off. It's not lifelong.
Wow.
And so I say, you know, what you're doing, we're talking about quality of life, and we're also talking about self-esteem. And I can't tell you in 50 years from now, when they look back at our use of medication, what people are going to be saying, whoa, do you believe what they were doing then? But I can tell you 50 years from now, someone's self-esteem that has been majorly impacted by failure. And 80% of the prison population, ADHD, untreated.
80%.
Wow. People, because what happens? People self-medicate because they feel bad and they start doing other things that have gotten them into jail. And so I say you're really impacting lifelong in a very, and this can be in a very positive way. So medication is a huge issue, and one that I encourage to at least give it a trial, because now there's so many available medications out there. So no offense to therapists, but all the talk therapy is not going to change the brain development.
Right.
It is going to help with being supportive. But to me, the best combination is counseling for support, coaching, and then medication part, and intact families where they're rooting for their children. These are the families that have the best success overall.
It's a real comprehensive outlook that you have, and I talk to my clients a lot about building a team. You know,
and the child is part of the team. Yes. I always say that to them.
Yes, them actually contributing to it and giving their own ideas, and
feedback.
Yes.
Yeah.
Mm-hmm. You mentioned the different medications, and then I wanted to ask you about GeneSight. So.
Okay.
Yeah. So.
Okay.
Tell us about that, please.
Yeah. So, well. We can do this in two parts. I can talk to you about pharmacogenomics, and then I have some pictures here that are very helpful to understand what the medications do. So we used to do a flip of the coin, basically, for how do you choose a medication? But pharmacogenomics is now a huge field, and one that I have gotten involved in over the years. So GeneSight is one company. Now so the GeneSight company, unfortunately, had difficulties with their data for ADHD meds, and so now they don't. I don't use them anymore because they can't process. They can do all other medications, but they don't do ADHD meds until they submit to the FDA and get approval again. Then there was a company called Genome, and Genome, I really love this company, and they do a fantastic job. And they have, for physicians, they have all kinds of conferencing, and so I just did a webinar with them about the antidepressants in one particular gene and how that affects those different things. And then, but the problem with Genome, which is a very easy swab of your cheeks and taking your cells and mailing it off, it went to King of Prussia, Pennsylvania, and then, but they stopped taking Medicaid, and that became a huge issue. And the cost, it's a $6,000 test, but their cost, no matter what, out of pocket, was $330. So people with insurance, because most insurances reject it, would have to pay $330. GeneSight was $330. Genome was $325. Now I've moved on to a company called Tempus, Tempus, and I've just begun with them over the last month, I would say. And very interesting. They offered an educational evaluation for me. So, and they mail you a kit and you spit into it. So it was pretty easy. And it was fascinating. So I did it. And I just got my results. And interestingly, I had suspected a particular gene, unusual gene difficulty. And and it confirmed it. So in pharmacogenomics, let me see. I was actually reviewing someone's testing. So what they do is they look at two sets of genes. They're called pharmacokinetic genes and pharmacodynamic genes. Pharmacokinetic genes are the genes that are in your liver. And they're enzymes, and these are the enzymes that metabolize your different medications. You take Tylenol, Advil, they have to be metabolized, and these are done by pharmacokinetic genes. One particular one, the most popular one, is one, and I don't know how technical you want to get this, but it's called the Cytochrome P450 system. And then there's all these genes that are listed in this Cytochrome P450, and this is what's in your liver, and this is how you metabolize medications and use them. Well, there's one called CYP2D6, and 2D6 is the most common. Well, many years ago, probably 10 to 15 years ago, there was a girl, and a 10-year-old girl who was having her tonsils out at the University of Minnesota Hospital. And normally when kids have their tonsils out, they are done that day, sent home with some codeine for pain, and they do very well. This child went home, surgery was fine, no bleeding at all, took her codeine and died that night. And what they discovered was that she is what's called an ultra rapid metabolizer with this particular gene, 2D6. What happened was she metabolized the codeine so fast that codeine gets metabolized in your body to morphine. And basically she overdosed because of her genetic variation. And so and so it became something that then the American Academy of Pediatrics then sent this out to all the pediatricians. Be careful with coding, because this is what happened, and she's an ultra rapid metabolizer, and this is not a standard test that you can order. So anyway, I got interested in this for my own family, because my father, when he was very ill and was taking was on some medications in a hospital, became very psychotic. And I got involved with his medications, and I thought about it, and I asked the physician to stop a particular medicine, and he returned to totally normal. And so in the back of my head, I've always thought, well, I'm an ultra rapid metabolizer of 2D6.
Oh, no kidding.
Yep.
Wow.
Yes. So it's good information to have. Mm-hmm. And then so those are the pharmacokinetic genes. And then the pharmacodynamic genes are the genes that are working within your brain and how you're metabolizing. And there's 3 neurotransmitters in the brain. There's serotonin, norepinephrine, and dopamine. And these are the 3 major ones. And how these genes affect that and how they affect medication is really also very important. So this pharmacogenomic field is fascinating. However, it is not one that has been really looked at well in children. And so if you talk to many child psychiatrists, some will say, I don't want to hear about it. Don't even tell me about it. And then there are others that, like the head of the Connecticut Children's, Lisa Nemero, who is a fantastic child psychiatrist, swears by the pharmacogenomics and loves it, and will speak at length about it. And so I think it's another adjunct to how to prescribe. So why not choose a medication? Why not choose a medication that may be better for you based upon your genetics? And so I always discuss it with families, but I say, why don't we, based on your symptoms, why don't we try X medicine and see how you go? And I always do the adage of low and slow. Start low dose and go nice and slow, and it tends to work pretty well. So, it's something.
That's great that you have that gradual approach, because that is one of the biggest concerns that my clients will come in with is they get, these are powerful drugs. I mean, they are. They get very worried about, is this the right dosage? Am I taking too much? What time of the day should I take it? Very, very specific questions that they have and that they're really unsure of, because they do want to get it right and they do want to feel better.